We talk about epidemiology. Basically, we have observational studies, descriptive studies, analytical studies, and experimental studies. Okay. So, among the what is observational study? Well, what do you mean by observational study? What is observational study? In just lay language, what is it? Tell me. Not for you all three of it, for you too. What is observational study? Something which you found, that is observation. Descriptive is again something, but you are describing in detail. Okay. Now, for example, I say that 5 people are in this room, or rather 6 people are in this room. 3 of them are wearing spectacles. Okay, that is an observation. Descriptive, I am being more descriptive. I say 2 girls and 1 boy are wearing spectacles. Okay, so observation is just a basic thing. Descriptive is slightly more. So, observation is what you see at that particular point. Now, suppose, say for example, if you do a survey of something and epidemiological design, you have observational on one side and the other you have experimental. Experimental is intervention. Experimental can be a clinical trial or a field trial, or it can be a community intervention trial. And observational is what I told you, it can be a descriptive, which is a longitudinal, which is going forward in time, cross-section, which is just at that particular time, what I am saying. Like what I saw just now, 6 of you all are 5 of you, there are 3 people with specs in this. Okay. Cross-sectional is you are following, that is the cross-section. And longitudinal is you are following it up for some time. Again, analytical, you have case control and cohort. And so, what is a case control study? So, cross-section is a cross-section of the population. Okay. Now, in your class, there are 150 students, right? How many have passed the second MB? How many have passed second prof? Huh? First prof. Okay. How many have passed the first prof? How many tell me roughly? 70. So, out of 70 people, only 4 people have come. 5, 1, 2, 3, 5. Okay. Only 5 people have come. So, that cross section you have to take has to be very small. But if more people come, then out of 70 who are passed. If 30 people come, the cross section will be more. So, I cannot take a small sample just with 5 of you all and do this. That is what a cross section of population comprises of whole population or sample of the whole population. Okay. So, this is we have some cross-sectional studies called prevalence studies. This is number of prevailing cases divided by number of population into 1000. Here what is happening is we are having a simple observation of population one point of time, individual based. It measures the exposure and effect, and exposure can precede or follow the effect. What do you mean by exposure can precede or follow the effect? You have fever and you were sitting next to a man who was coughing in the train. After 2 days you develop fever and cough. So, you say that why you developed fever and cough? Because I was sitting next to this man who also had fever and was coughing very heavily. We cannot be sure which came first, right? So, exposure precedes or follows the effect. Then we have description, cross-sectional study, population community study. So, this estimates the problems only and the prevalence. And descriptive cross-sectional studies slightly more. What is the disease all about? Does it affect children more than adults? Does it affect males more than females? What are people it affects? Okay, disease, disability and symptoms of health. Dimensions of positive health such as fitness. Attributes related to health like body measurements, blood pressure, etc. Okay, for example, a person who is fasting, do you expect his blood pressure to increase or decrease? Various studies have to show that. Okay. So, this is a cross-sectional study. You have, first thing is sampling. You have a reference population, then you take a sample population, and then you see these things. There are 4 categories. One is people who have a disease and who have been exposed to the agent. One is people who do not have a disease, who are also exposed. Not everybody is exposed to not everybody who is exposed to an agent gets a disease. Okay. The third one is no characteristic of disease, no characteristic of exposure, but disease is there, and no characteristics of exposure but no disease. So basically 4 categories. Is it clear? So just because I am sitting next to somebody who's got TB, I may or may not get TB. I am going from here to Kolkata in a train, and my next door fellow is my guy next to me is coughing out. He's a TB patient. I may get TB, I may not get TB depending on my immunity. So that is the first thing. I am exposed to TB, but I get a disease. I get TB. Second one is you are exposed also. You are sitting in the next bench, next seat, but you don't have a disease. I was the poor guy. I got a disease. You are sitting there. You didn't get it. Third one is this guy. He has not been exposed, and he's got no disease either. Fourth is she. She's got no exposure, but she's got disease. So there are basically 4 categories. So here you state the criteria for disease, define co-variables to be measured, examine ethical issues, identify the reference population, inclusion-exclusion criteria. So you have to identify the disease. So people presenting with a cough after a train journey. People presenting with a chronic cough after a train journey. So train journey, you're sitting in the AC compartment for 4 hours or non-AC for whatever, and you have a cough. So that the condition should be criteria for disease, and define co-variables to be measured, examine ethical issues, identify the reference population and inclusion-exclusion criteria. Determine minimum number of samples required. So as I said, I cannot do a study on 5 people out of 70 and say that this batch is very good or very bad. I need more people. At least 30 people should come, and then only I can say proper class is there. Okay, 5 of you are coming, there is no class actually. So sample size. Select study subjects through appropriate sampling procedure. Define measurement procedures. Like for example, if you want to check the blood pressure of all medical students of your batch, so you need to have proper BP apparatus, you need to have a proper measuring stuff, and then you can define measurement procedures, carry out data collection and clinical examination of whatever is necessary. So for example, this is the basic thing, cross-sectional study, AD by BC. You have a risk factor, you have people with a disease. What's your name? What's your name? Your name? Huh? Anshuman, your name? Sharmila. Show me. Okay, Anshuman. Now you look at this and tell me how many people are suffering from disease. How many people are suffering from the disease? Disease take a cause and book. Just tell me from this. A plus C. Yes, A plus C is the people suffering from the disease. Now you tell me how many people are exposed to the factor. How many people are exposed to the risk factor? Only A. People who are exposed to the risk factor, A plus B. So this is the people with the disease is A plus C. People who are exposed to is A plus B. Is that clear? Just remember this basic table. So here we have the same thing. A study, 1,000 people, men above 30 years are there, and their BP is checked. And we are getting this data. We are looking at the risk factor of smoking and hypertension. Now you tell me from this, how many people have hypertension total? Hypertension. We are studying hypertension. How many people have hypertension total? 150, very good. How many people don't have hypertension? You tell me. 850. How many people are smokers? Totals, how many are totals? How many are smokers? How many smokers are there? Total smokers, how many are there? 100? 400, very good. And non-smokers? 600. So this, you have a figure. So total people with diseases 150, total without disease 850, total population is 1000. So here we are trying to see whether smoking increases the risk of hypertension. Okay. So this is a descriptive, this is an analytical study. So what is the prevalence of, now tell me, prevalence of hypertension among smokers. So, what's the name? Anshuman. What is the prevalence of hypertension among smokers? How many people have hypertension among the smokers? Huh? No, tell me, just explain to me now. 120 smokers have, out of 400 smokers, 120 have hypertension. So 120 divided by 400, that is the cases among exposed. But there is also hypertension among non-smokers, not just smokers who are getting hypertension. Non-smokers also are getting hypertension. So how many non-smokers have got hypertension? 30. 30 divided by 600, that is 0.05. So from this, what do you make out? Prevalence of hypertension among smokers is 0.3 and hypertension among non-smokers is 0.05. What do you make out of this? What do you understand? Huh? That I understand, but how? How? So then we divide those two. 0.3 is divided by 0.05. It comes to 6. That's called the ratio. And then we have also something called the odds ratio. Odds ratio is basically AD multiplied by BC. Okay, AD multiplied by BC, that comes to 8.14. She is not very happy. Yes, nodding head, but she is not very happy. বুঝতে পারছো না? বুঝতে পারলাম না। Odds ratio তুমি বুঝতে পারবে। আচ্ছা ঠিক আছে বলছি। Odds ratio তুমি just প্রথম এটা দেখো, A first column হচ্ছে A, second হচ্ছে B, first cell A, ডান দিকে cell B, third cell C, fourth হচ্ছে D. So just remember this formula, AD by BC. Don't break your head about it, about what is A, what is D, what is মাথা ঘামাতে হবে না। AD by BC is the odds ratio. So when the odds ratio is 8.14, it means that there is 8 times more risk of getting more risk of hypertension among smokers. Okay. So now that is so this is the meaning of odds ratio. 8.14 means the greater chance of getting this from the smokers. Now here then we'll go to case control study. So आगे चलो epidemiological study. We looked at cross-section, experimental, observational, analytical, and descriptive. Descriptive mode case control and cohort. So case control is the easiest study because the event has occurred. The event has occurred. What is the event? Somebody's got a disease. Okay. Say for example, somebody's got chickenpox. Number of cases of chickenpox in this season. That is the positive. That is the case control. So you're looking at chickenpox cases in the month of January, February, March. So the case is the case of chickenpox. Okay. So that is the case control study that compares people who have a disease with patients who do not have a disease. Now, for example, if I say that people with chickenpox have greater weight than people who do not have chickenpox, they have to have some data with me. So then only I can do it. So the people who have disease or outcome disease with people who do not have the disease or outcome. Okay, so here we are looking back retrospectively. ঘটনাটা হয়েছে, okay, এই নয় যে ঘটনা হবে, হয়ে গেছে. So somebody is fallen ill, we are wondering why it's fallen ill. Like for example, Nipah. দুটো কেস হয়েছে নিপাতে in West Bengal recently. Another died. So we are looking at Nipah and what are the possible causes. We are going back in time. So that is a case control study. So it's also called retrospective study, and here also they estimate odds. The odds represent the ratio of the probability that the event will occur divided by the probability that the event will not occur. So case is a person who's having the disease or whatever you say. Okay. Now that has to be defined properly. Say for example, a person is You are taking a person who's got disease, तो तुम्हारे बोलते हैं you are taking all cases of chicken pox or all cases of diarrhea. You know, under 5 children or 10 under 5 children, you are taking all cases of diarrhea. That is your case. Then the other control is people who do not have diarrhea. They are also children, but they don't have diarrhea. That is your control. So cases is person having the disease, health disorder, condition under investigation. Control is person in a comparison group that differs in not having the outcome being studied. Okay. When এমনি সুস্থ আছে ওই particular জিনিসটা নেই. So you have one group যার diarrhea আছে, one group which does not have diarrhea. Okay. So case control, both exposure and outcome has occurred, and the study proceeds from backwards from effect to cause and uses a comparative group to verify or refute the evidence. When either you are supporting it or you are refuting it. Now, for example, Nipah. How does Nipah spread? How did it spread? Suppose I say the 2 cases in Nipah, they had khijur rush. I'm just saying khijur rush is a risk factor. So then I have to get another group who also took khijur rush but did not have Nipah. দুজন খেয়েছে খেজুর রস তারপর নিপা হয়েছে, but I'll have to take another group who have also taken খেজুর রস but have not had Nipah. বুঝতে পেরেছো? That is the same thing, and they should be matched for age and other things. So where exposed, where not exposed, these are cases, and these are the controls. Do not have the disease but were exposed. খেজুর রস খেয়েছে কিন্তু নিপা হয়নি, হতে পারে. So this is the control and this is the disease. So for example, you are looking at cancer cases, you are going backwards. Ki hote pare cancer. You are looking at some food habits, the environmental factors or other thing, and the control group also, and then you are identifying the risk ratio. So selection of cases and controls, the most important thing. Then matching. Matching means, what is matching? What is matching? What is matching? Bolo. What is matching? Bolo. Huh? Category, no, you're matching for certain criteria. Match courses, like, why do you all, I'm really asking the girls, do you all match your clothes? Do you match your clothes? Like for example, latest craze is what do you call it? Chords. Chords, no. Chords means coordination. Upor niche aki dress. It was not there now, that is a fashion. That is called matching. So matching means you are looking for as similar to that original as possible. Suppose duto khejur jara more geche nipa got with both of them are nurses. So we were of the same age of 25, 26 years, whatever it is. So we have to take a matching case which is also around the same age. You cannot take somebody who is 45, 70 years. If you get somebody who is 25 years, almost same age, that is called matching. Okay. But again, matching, maybe staying in same locality also or having same socioeconomic status. These are all important things. So if you cannot match a person, they were staying somewhere, and you cannot match them with somebody staying in, say, Park Street. You have to match it with the corresponding age and other factors. That is called matching. Measurement of exposure, analysis of and interpretation. So selection of cases, definition of case. What is a case? You have to have diagnostic criteria, eligibility criteria, and here the thing is, you can fix your definition. Like, what do you mean by a Nipah case? For example, I'm giving an example of Nipah because we had it. So a person who is confirmed as Nipah is considered as a case. Or let's forget Nipah for the moment. Let's talk about some other disease. Like person suffering with chickenpox, he is considered as a case. So how do you know he's got chickenpox? You are looking at his lesion and diagnosing it as chickenpox. But suppose somebody says, no, this is not chickenpox, it's measles. Suppose somebody else says it's not chickenpox. Then the question comes. So what is diagnostic criteria? Means either lab diagnosis or a clinical diagnosis. Okay. So clinical diagnosis, often we see something, but either lab diagnosis, for example, dengue. Dengue, you have a lab diagnosis, that is the diagnosis. Or for that matter, malaria. But sometimes you feel that this guy is got fever, but his test is not positive, he looks like having dengue. Then becomes a presumptive diagnosis. So, sources of hospitals, cases, hospital and general population. Selection of control, I told you. The controls will be free from the disease, and selection of control is most difficult actually. They can be from the population, general population, hospitals, relatives, neighborhood. So everything should be same as much as possible except for that particular disease. Then matching. So we select control in such a way that there is with the age, certain things are almost matched. Like for example, age. You cannot compare a 25-year-old person with a 60-year-old person in terms of health, because 60-year-old person may be having more problems. 25%, 20-year, you cannot compare yourself with me or with some other professor because of the age factor. My body is not like your body, so that's the matching. Then you have also what is called confounding factor. Confounding factor is something which adds to the puzzle. So, for example, esophageal cancer, both smoking and alcohol are both causes. So, you can't just say one. That is a confounding factor. What is a confounding factor? And this is an example. Then measurements of exposure. How do you get the measurement of exposure? Interview, you ask the patient directly. Questionnaires. Then hospital records, employment records. Okay. Now, what is today as far as public health is concerned? What is today is what day? You know, what is important today? Today is World TB Day, World Tuberculosis Day. Okay, this was the year, this is the day in which Robert Koch discovered the TB bacilli. So, why I am saying this is, why I said this is, he diagnosed it, he came to Kolkata also and worked here, and a lot of people had TB. Now, here, measurement of exposure. Now, how do you get TB? You get TB, you have to get it to somebody, but that person may not be obvious. Now, one particular thing which we had in Kerala, I belong to Kerala, was that it's a question which was raised to many years back, still has no answer. Many of, we can say 1/3 of Kerala, or maybe 1/4 of Kerala work in Gulf countries. Okay, 1/5 definitely work in Gulf countries. So, the problem is that when they come to, they're working their guts out in Dubai or Bahrain or wherever. When they come to Kerala, when they come to India, that's the time they go for checkups. Then suddenly the test is done, sputum positive, it comes out as TB. The problem starts from there. TB treatment is given free in India. You're getting dots, etc., etc. But somebody has to take the medicine straight from here. Somebody has to come and collect the medicine. We cannot give the medicine to him to take to Saudi Arabia or. So what happens? He does not take the medicine because he cannot carry it in his luggage. They'll ask where is the prescription, and many countries are strict regarding. The result is that he is not able to take the medicine, and the thing is that he probably dies of TB. That is the first point. Second point is that if he discloses that he's got TB, the country may not take him inside. Country will say, okay, you stay back. You got TB. We don't want us other workers to get infected. You stay back in your country. So he will lose his job. So it's a very deadly combination. That is why past records, hospital records, and employment records. Then exposure, find out the exposure rates between among case and controls to suspected factor, estimation of disease risk, estimation with exposure. That we talked about this. Again, smokers and lung cancer. Now, you tell me how many non-smokers are there? Tell me. How many non-smokers are there? How many non-smokers? 29. How many smokers are there? 18. How many smokers are there who have lung cancer? Huh? 30. How many lung cancer cases are there? How many lung cancer cases are there? 35. Out of which 33 are smokers. Okay. And 2 are non-smokers. So we have 29 non-smokers, 88 smokers, right? So these are all smoking for more than 5. So this is the same thing. Total cases are 117. So exposure rate is A by A plus C. That is number of cases, number of smokers divided by with CA lung divided by total number of cases. That is 33 by 35. That is 94.2. And control is, who are the control? Without CA lung. They don't have CA lung, they have COPD or some other disease, or maybe nothing. There are 55. 55 out of 82. That is 67. So frequency of smoking is higher in lung cancer patients than those without cancer. This is clear. Have you taken a screenshot of this figure also? Okay. So this is very clear. So then comes next one. So odds ratio. Again, we talked about odds ratio. Ratio of the odds that the cases were exposed to the odds that the controls were exposed. So here again, AD by BC. What I told you just now. Odds that the case was exposed, A by C divided by B by D, that gives you AD by BC. Now, you ask me, sir, AD by BC, so don't break your head regarding that. MBBS level, just remember, AD by BC, actually, it's A by A plus C divided by C by C plus D, which brings it to AD by BC. Okay. So here in this case, AD by BC is 8.1. AD by BC is 8.1. So smoking is found to be associated 8.1 times more in patients with lung cancer than those without lung cancer. Okay. So this is again for another study was done in USA. The odds ratio is 4. This means that people who have a high fat diet have 4 times the odds of colon cancer than those people who do not have a high fat diet. As the more the odds ratio goes, the greater the association. But odds ratio need not always be on the higher side. It can be negative, it can be 0. 0 means there is no association. Negative, when does it become negative? When does it become negative? Bola? It can become negative if there is protective effect. Suppose I am giving a vaccine, a new vaccine, and I am seeing the effect of cancer of that or the disease. So then the odds ratio becomes less. Now, for example, what is the new vaccine which is being brought out? What's your name? What's your name? Anusha. Which new vaccine is brought out now recently? Very recently? HPV vaccine. So HPV vaccine once it started, the HPV vaccine starts, so there should be normally there should be a decline in the number of cases. So if you do a study after 6 months or 1 year, you will find the odds ratio is negative, which means protective effect. Okay. So odds ratio on the higher side always means more association, but when it's negative, it means the protective effect. So once the HPV vaccine starts, and you should find the number of cases being much less. So advantage of this is that good for studying rare conditions, less time required, multiple risk factors, but can answer questions that could not be answered through. This is the advantage of case control study. Okay, advantage. It's all there in your books, you don't have to break it. Disadvantage is that they rely only on memory. So memory is a very big thing. So, for example, तुम्हारा body कौन है? Body? Body? Gorakhpur. Suppose I ask you, 10 दिन आगे, होली दिन की क्या चीज़ है? I'm asking you, होली दिन की क्या चीज़ है? पता है क्या चीज़ है? बोलते हो कि ना बोलो? हाँ? कि? हाँ? Accurate, however, because so that's what it's important, memory. So you cannot say that it's a habit. Suppose she says, I had food during Holi, তারপরে পেট পাতলা পায়খানা হয়েছে. You are saying to money in a holy key. So that is the most important thing. Rely on memory, and people with the condition will be more motivated to recall risk factors. वो बोलते जे अभी पुचका खाওয়ার জন্য আমার পেট খারাপ হয়েছে वो बोलते কিছুই আমার তো মনেই নেই কবে হোলি কি হয়েছে so that is called recall bias. It can be difficult to find a suitable control group. Incidence cannot be measured and not suitable for evaluation of treatment. ठीक है जी. So cohort study is the other one. Case control is one. Cohort is the other one. Cohort is basically a group of. The name came from the Russia. I mean the term for Greek from Romans. A group of soldiers marching. That is called a cohort. So here is undertaken suspected cause and disease. So here there is a twist. You are following up the same group for a number of years. Okay. Now suppose Panjan Tumracho. I am following you after 20 years. After 20 years, I am trying to find out whether any of you have got blood pressure. 30 years. I write letters to you all, come, tumhara blood pressure check karo, tell me what is your blood pressure or tell me they are getting treated for blood pressure. Fine. That is how a cohort study works. So, that is one way. So, here we can find out the suspected cause and effect. So, presence or absence of risk factors determined before outcome occurs. Now, suppose I say that I am trying to say that I am following up for your group for 10 years. However I follow it up, I find out ki oshud khacho, ki hocche ki na hocche. You send me details. So, I am presence or absence of risk factors determined before the outcome occurs. And then you are looking for the outcome. So, you can have a birth cohort, marriage cohort, exposure cohort, synthetic cohort, etc. People who have the same group who are in a different period of time. So, cohort studies can usually also called longitudinal studies. It goes forwards, prospective studies, forward-looking study, and starts with people free of disease. Okay. So, right now, none of you have any major disease, but 20 years later, some of you may be having diabetes, some of you may be having hypertension, some may be having dyslipidemia, whatever else. Okay, very natural thing. So, starts with people free of disease, assess exposure baseline, assess disease status at follow-up. The indications is when there is good evidence of exposure and disease. When exposure is rare but incidence of disease is higher among exposed. When follow-up is easy, cohort is stable, and when funds are available. Now, what is the problem with cohort study? Cohort study, the problem is that it's not easy to get all of 5 of you all, or 6 of you all, or 70 of you all. Not easy to follow up. Why it's not easy to follow up? You see, we had a similar thing in medical college many years back. So, somebody wanted to do a study over the forceps delivery. Forceps delivery is a delivery done by forceps. When the head, the instrument is kept here. So, whether that causes any neurological deficit. So, how to do study? So, a neurological professor told a gynae professor that this is a good idea. So, they said we sent postcards to all the mothers who delivered at Eden Hospital, Calcutta, Medical College, and told them that last 10 বছরে আপনার বাচ্চা যদি জন্ম হয়ে থাকে আর এই কন্ডিশন যদি থাকে তাহলে মেডিকেল কলেজ আসেন। কন্ডিশন কি ছিল? পড়তে খারাপ বা কিছু একটা নিউরোলজিক্যাল প্রবলেম আছে এইসব করে। So we managed to send the postcards and around 200 people came. 200 people came, genuine people were probably 60-70. বাদ বাকি 140 আমার ছেলে ভালো পড়ছে না, আমার মেয়ে পড়ছে না, ছেলেটা ফুটবল খেলে, হ্যাঁ, nothing to do with neurological thing. But we brought them. Nearly 200 people came, but we got 60 genuine people who were the cases. So cohort study is not easy. That is one thing. আমরা 200টা পেয়েছি, it was a very big thing because after 10 years, how many people change their addresses? So many people don't. Nowadays, people change their address even faster. তখন তো একটা বাড়িতে থাকতো 10 বছর তো ওখানে পড়ে আছে। Now they change the house every 2 months. They change the address. Go to Bangalore or go to Pune or some other place. They don't stay for more than 3 months. He's looking for some other address. So okay, now you can say now we have mobile phone. Yes, by mobile phone you can contact. True. So the point is the loss to follow up is a very big thing. It's quite costly also. And so you need funds also. So here you have exposure outcome. This is it, case control study. The case it's already occurred. The case is already occurred. We now in the cohort study, on the other hand, you look at the population free of disease. Factor is present. Factor is absent. Then you have disease, no disease, disease, no disease. Then again, study begins from this particular point. Okay. Right. Now, suppose I say that after studying 5 years in Santiniketan Medical College, you are having cough and respiratory tract problems. Why? Because of the traveling in totos and the pollution and blah blah blah. So exposure factor is traveling in toto and disease after 5 years. What do you have? Whether you have COPD or some no disease at all. Okay. So population people without disease, exposed, not exposed, disease, no disease, disease, no disease. So same thing. Study cohort, comparison cohort. You're looking at one group. You're looking at another group which is not exposed. One group is exposed. And again, cohort you can have prospective cohort study or retrospective. Prospective means you're going forwards. Retrospective, you're going backwards in time. So, for example, as I said, people who delivered in medical college 10 years back. That is a retrospective cohort study. And you can have a combination of retrospective and prospective also. Okay, so study starts, disease occurrence, and here this is a prospective cohort study. Okay. Retrospective is study is already starting, but you are going back in time. Disease is already also occurred. So you have also retrospective ambidirectional cohort studies also there, which go in both directions. So when you go for a cohort study, both the cohorts are free of the disease. Both the disease should be equally susceptible to the disease, and both should be comparable. Diagnostic and eligibility criteria for the disease should be defined well in advance. Okay. Now I am just giving an example of a cohort study, simple cohort study. Just for sake of argument, I sent a mail to all of you after 5 years, and I say that please let me know your BP, what's your BP or your current status. Then I say again comparison. So one group is, say I take boys, one group I take girls. So both groups should be equally susceptible to disease. Boys are also susceptible to hypertension, girls also. So I am taking that. And they should be comparable. Diagnostic and eligibility criteria should be well in advance. So say again, selection of study subjects, obtaining data on exposure, selection of comparison group, follow-up analysis. Okay, here again, this is the thing. Selection of people. You select the occupation group or professional group, and persons having exposure to some physical, chemical or radiological or biological, like X-ray exposure to radiologists. Okay. Now, it's a good. What could be the reason? Like people who have a professional singer, for example, a good professional singer, he can suffer later from laryngitis. He could suffer later from cancer also. Okay. Just so you can take an occupation group, which is for composing singers, dancers, etc. Exposure groups, people who have exposure to some physical, chemical or biological agent. Obtaining data, again, personal interview, review of records, dosage of drug, radiation, etc. Medical examination, special test, blood pressure, cholesterol. Obtaining data on exposure, water and air sanitation status, and here again we can get the class cohorts as exposed and non-exposed, and also by degree exposure we can subclassify cohorts. Internal comparison, only one cohort is involved in study. You are doing within that cohort itself, you are comparing it. The other one is more than one cohort. Say a cohort of radiologists compared with a cohort of ophthalmologists. Okay. So why am I comparing radiologists with ophthalmologists? Any idea why I am comparing radiologists with ophthalmologists? I am looking at cohorts of radiologists versus ophthalmologists, following them for 5 years. My issue is cancer. I'm wondering, I look at the cancer cases. So one group I'm taking radiologist, one group I'm taking ophthalmologist. Why am I taking radiologist? Because radiology, cancer is a hazard of radiologist, not of ophthalmologist. Okay, ophthalmologist is just checking somebody's eyes, doing a cataract operation. But there is a real radiation threat in the case of radiologists. So if no comparison group is available, we can compare with general population, or say for example, cancer rate of uranium miners with cancer in the general population. Then follow-up to be either by what is follow-up? Finally, you are seeing the morbidity or death, Bail questionnaire, telephonic calls, personal interviews, periodic medical examination, follow-up. The follow-up is the most important thing. Very often we cannot get anybody in follow-up because body change koreche, shift koreche, people have, just like a college reunion. You have 150 students here, next 10 years you will not be having a reunion. But after that you become a bit old, you say let's see, let's organize some, she calls you up, you call him up, you call him up. Out of 150 people, only 30 will respond. Then after gradually, some of you we'll also come. Then gradually it will increase. So follow-up is the most important part of the study. Loss to follow-up is due to death, change of address, migration, change of occupation, and loss to follow-up is one of the main problems of this cohort study. Okay. So analysis, calculation of incidence rate among exposed knowledge, this we've talked about. We've talked about this thing again earlier also. Incidence rate. This gives you an incidence rate. Incidence rate means the actual number of cases. That is, how many cases are there? How many people have disease? How many people have disease? Follow? How many people have the disease? Huh? A plus A. And how many have been exposed? A plus B. So how many have got a disease and have been exposed? A percentage of those who have got a disease and have been exposed. A by A plus B. Incidence among exposed is A by A plus B. Is this part clear? Huh? Incidence among exposed is A by A plus B. A is what? The people who have got the disease as well as exposed. So total A plus B has been exposed, out of which only A has got a disease. So A by A plus B, that is the incidence among exposed. C by C plus D is incidence among non-exposed. Okay, then we have two terms, attributable risk, which is incidence of disease among the exposed minus incidence of disease among non-exposed. So A by A plus B minus C by C plus D divided by A plus B. So this one, we find out the relative risk, and you can take a screenshot. I am not going to take much more time on this. So how many people have relative risk and attributable risk for above data? Okay. So here we have 70 people out of 7,000 have what? 70 out of 7,000. What do they have? Huh? Incidence among exposed is A by A plus B, that is 70 by 7,000 is 10 per 1,000, right? So incidence of lung cancer among smokers is 70 by 7,000. Now lung cancer among non-smokers is 3 by 3,000, that is 1 per 1,000. So what does it mean? So what does this figure mean? 10 per 1,000 and 1 per 1,000, what is the difference? Yeah, so it has a 10 times more risk of that. So relative risk is 10 divided by 1, which is 10. So lung cancer is 10 times more common among smokers than non-smokers. And attributable risk is 10 minus 1 by 10 into 100, which is 90%. So 90% of cases of lung cancer are attributed to their habit of smoking. Is this clear? Is this clear? So that's one of the cohort study can actually get actual relative risk estimation, can examine rare exposures, can establish cause effect and minimizes information and selection bias. But the flip side is, again, this can be done where randomization is not possible. More than one disease related to single exposure. Multiple exposures can be studied, and magnitude of risk factors effect can be quantified. Okay. Weakness is that it takes a long time to complete, expensive, and then ethical issues. What is the main ethical issue? What is the main ethical issue here? What is ethics, first of all? What is the main ethical issue? Huh? Not privacy. Somebody is doing something and you just to do a study, chalo, continue doing the same thing. Somebody is saying, he's saying 2 pegs of whiskey every day. You want to do a study on whiskey. You're not telling him to stop. You say, chali jao, I'll get my thesis done. I'll get my data done. You only worry about it. Actually, you should tell him, stop drinking. He'll end up with cirrhosis. Okay. So that's just the thing. That is the main ethical issue. So because you know he's got a possible risk factor, but you're doing nothing to stop it. A non-response, migration, loss to follow-up, unexpected environmental change may affect the situation. So this is again regarding TB. So this is regarding your case control and cohort study. Now the main stuff. I went this way because your friends have already basically we talked about all this. Here the question is, this is the heart of the experimental study. Did the investigator intervene? If it is yes, it's experimental study. Then comes random allocation. Then if it's random allocation is done, it's called a RCT. If it is not done, it's a non-RCT. The other one is there is no intervention, it's observational study, comparison group, case control, analytical and descriptive study. So here we are talking about in observational study, researchers don't have any control. Here you have a control over the thing. This is a new drug. I have got a new drug. I am going to give this to so and so people. So I have control over it. Okay, they have researchers have control over key variables in the study. And here I am giving this to 3 of you all. The other 3 I am not giving it. So the 3 of you all, how many of you? 5 of you, sorry. 3 people I am giving this drug, 2 people I am not giving the drug. I want to see whether the drug works for you 3, and I want to see whether this drug works for 2 of the other drug works for 2 of you. So other drug may be the same drug, another drug, or it can be a placebo. That is called the investigator controls exposure to the risk of treatment by assigning subjects to one group or another group. Individual assigned a group and the exposure is forced upon them. So treatment group, 3 of you are treatment group, 2 of you are control group. So outcomes in treatment. Suppose I say, for example, what is your favorite paracetamol? Paracetamol tablet. Paracetamol tablet, Calpol. Yes? You don't know. Yes? Yes? Dolo. Okay, fine. Very good. That makes it easy. So I am comparing, I am giving 3 of your Calpol, I am giving you 2 of your Dolo. I am saying which is more effective. You have fever, they also have fever. We are comparing this. I am saying that Dolo is better, somebody is saying this Calpol is better, somebody is saying Crocin is better. So you are comparing the alternative no treatment at all. Okay. Groups treated identically except for the intervention. So deliberate application of withdrawal of suspected causes or changing one variable while making no change in the control. So I am giving 3 of all Calpol, the other 2 I am not giving anything. I am maybe giving a placebo. Placebo is something which is of no use, no harmful or benefit is there. So I am trying to see whether this medicine really works. A new drug which says that you just give 1 tablet of Calpol, 4 times you don't have to give it, or 3 times you don't have to give it, that will be enough. Sustained release placebo, drug or whatever. So the aim is to provide a scientific proof of risk factors, provide a method for measuring the effectiveness and efficiency of health services, improve health of the community. So first we had animal trials, experimental trials among animals, testing efficacy of therapeutic and preventive measures, understanding natural history of disease. So previously every hospital, every college used to have a animal house, animal land, Then the protest came, this PETA. Have you heard of PETA? People for Ethical Treatment of Animals. They said you are torturing dogs and cats and all. So all the animal experiments have more or less stopped. Okay. So then we have human trials. So why human trials? Animal trials, even when they were there, what is happening to animals, we cannot say whether it is same thing will happen to humans. So we have a different body constitution. You're giving something to a rat, that will not necessarily happen to us. You're giving the medicine to a guinea pig. For us, it will be something different. So that is why human trials. Now the question human trials is, a problem with human trials is that somebody has to first volunteer for a trial. The company calls for a trial, a new medicine, a new drug. So he needs some volunteer. Suppose I ask, how many of you will volunteer for a new drug? Raise your hands. Suppose I ask you, how many of you will volunteer for a new drug? Each of you will get 10,000 rupees. Raise your hands. Nobody is coming. So nobody will volunteer. I raise it to 20,000 rupees. Still nobody is volunteer. I raise it to 1 lakh. Maybe somebody will say, "ठीक है, हम बनेंगे, हम बनेंगे लाखपति." So that is how it works. Okay. So the benefits have to be weighed against the risk. So it's not easy to get a volunteer. So you have RCT trials, clinical trials, field trials, community trials. Then you have non-randomized trials, trials without control, natural experiments, before and after comparison. RCT first, forget about that, there's a yellow line. Population, how many are eligible? Exposed and non-exposed. Then again, disease, no disease, disease, no disease. This is a randomized trial. So you're giving a new treatment or a new medicine, and after that also, what is the trial? Now, as I said, today is World TB Day. About 20 years back, the government said that we are going to have revised National Tuberculosis Program, RNTCP. So here the issue was, what is RNTCP? Directly observed treatment short course. So the person who's taking the TB medicine, he will take it on alternative days and under supervision. Under supervision, some Anganwadi teacher or some nurse, somebody. After nearly 10, 12 days, they found that TB cases are not decreasing. Now they're saying, instead of directly observed, alternate days, you take the medicine every day. So the reason for that is the side effects. Okay. So for example, the breast cancer using tamoxifen, how effective is it? So here you're taking a big thing, protocol, selecting reference and experimental populations, randomization, intervention, follow-up and assessment of outcome. So first thing is you make a protocol. What are you going to do? Then selecting reference and experimental population, then randomization, intervention, follow-up and assessment of outcome. So here, what is the protocol? Protocol means you are taking what is the sample size, what is the control group, what is the study group, and what are you going to give? Okay. Now suppose I take 50 medical students, 50 nursing students. So I decide I am giving the nursing students this medicine, I am giving the medical students this medicine. That is the protocol. So decide the selection of study groups, control groups, size of sample, treatment to be applied, and once the protocol has been evolved, it should be strictly followed. And before that, you do a pilot study to find out the feasibility of the study. Okay. So reference population is the population to which it can be applied if found applicable. So if you do a study in Santiniketan Medical College, comparison of some drug use among the medical and nursing colleges, you are doing a study which is applicable in Santiniketan. But can you make a generalization for all the medical or nursing colleges? You can't. That is why that's a reference population. And experimental population, they should be eligible for the trial. They should give informed consent. Informed consent is very important. You have to get it signed. And also, if there is something wrong, some side effect is there, the company which is bringing the medicine, they should be in a position to give compensation. So this volunteer, I am getting 1 lakh rupee. I might be a volunteer. But after 1 lakh, after getting the 1 lakh, that drug has left me paralyzed. What is the use? I got 1 lakh, but my leg, I can't move my leg, or I have landed in a hospital. My hospital bill alone comes 3 lakhs. So 1 lakh pay ki karna. So that's why informed consent. This is important. Randomization is a harder trial. It's an element to attempt to remove the bias. What is bias? Bias means what can affect it, like your memory recall. That is one thing. And there is no selection bias. Okay. Now what is selection bias? I know he's a good student, so I'll always tell him to sit in the front bench. I know somebody else is a back bench, let him sit in the back bench. Okay. So that is I'm doing a bias. This is giving an example. I don't know whether you're a good student or a bad student. Okay. So we always think backbenchers come in front. Some of the backbenchers are very good students actually. They are sitting and watching something on the mobile, but their answers are sometimes very good. But for people sitting in front, they may be the ones who are not that good. So we just think. Okay, that is called bias. Participants are allocated randomly to either receive or not receive a specific intervention. So here is the randomization. Suppose what happens in randomization is that I had five people, right? I say go into 2 groups. One group go there, one group go there. What happens normally is that, hey, tu edike chole aaye, tu edike chole aaye. You know, amar bandhu ache, amar bandhavi ache. You come this side, you come that side. That is what happens. So that is, randomization is done to increase that the same groups are not the same and groups are matched in non-experimental ways. So here you just depends on random table. You just pick the table. You pick one number, 76. Somebody else picks up 26. Somebody else picks up some other number. So that is randomization. Okay. Then we intervene by deliberate application or withdrawal of the suspected risk factor. So for example, control group, no intervention. Use a placebo. Ordinary thing. Intervention is you are giving a new drug, you are giving a new vaccine, new procedure, and the final thing is the dependent variable. So, like for example, this pap smear. You are giving that pap smear now, and that is the final result should be that number of cases should be less. Then record keeping, selection of examiner study and control group at regular intervals, findings record till final assessment. Attrition is possible. Attrition means the number of cases may be less due to death, migration or loss of interest. Suppose you give vaccine for say 100 girls, this pap smear, and then 6 months you are following them, maybe 1 year you are following them. Initially they will all be very interested, but after 4-5 months they say, so they might lose the interest. So loss of interest is also there, because then your data suffers. Then tabulation of data by statistical significant test. Positive results means decrease in incidence of disease or improvement in the patient's health. Negative results means side effect of drugs. So you are giving medicines, but the results are negative. That means side effects are more. So bias, you can have subject variation and observer bias. Now then you have blinding. Blinding means the subject and investigator or both do not know which group the subject is assigned to. Okay. So suppose I am doing a study, I don't know which group is, I just 2 groups. I don't know which group is good or which group is bad. Random. Okay, that's called double blinds. The subject or the investigator or both do not know which group the subject is assigned to, and prevents people from being treated differently in any other way than the treatment itself. So single blind, patient is not aware. Double blind, both participant and investigator are not aware, and triple blind, even the analyzer is not aware. So to eliminate bias, most oftenly we have a double blind trial, where the participant and the investigator are not aware. Okay. Then we have what is called a crossover design. Crossover design means 2 groups, both are given treatment, same treatment, but after 3 months or 6 months, they change the thing. Like say for example, 3 months you are given one diabetic drug. After 3 months you are given another diabetic drug. Your group, you are taking the same one you exchanged. The reason is that we are trying to compare both the groups, and some of these medicines, they take time for the effect. It's not that if you stop atorvastatin today, tomorrow the cholesterol is not going to increase or decrease. It takes time. That is why a crossover study. You take this, then you after a few days let the effect go off, then you take the other one. That is called members of one group. Groups 1 and 2 receive both regimens. Group 1 receives treatment A, then treatment B. Group 2 receives treatment B, then treatment A. That's called a crossover study. Okay. Then this takes advantage of the control of most bias, confounding, high internal validity, tight control on exposure and treatment. Disadvantage is that it's time consuming, expensive, resource intensive, non-compliance and dropout is quite high. Ethical constraints. Ethical constraints, I told you, that is about the same thing. When you're not sure of a particular drug, whether to give it or not, that is the ethical issue. Okay. So, it's like you buy some food from outside, you're not sure of the food. But if you buy it from, say, some other reputed place, you have an idea that it's good. Ethical constraint may not mirror practice. Then placebo. Placebo is just another way to make both groups simpler. They just feel that they're taking a placebo, so placebo দিয়ে ভালো কাজ হবে। হ্যাঁ ভালো লাগছে, ওষুধ খাচ্ছে ভালো লাগছে, ওষুধে কিছু তাও ভালো লাগছে। So are placebos ethical? When there is no successful therapy, placebo is ethical, but withholding a treatment known to be effective is not. If you are giving, if you know that this person is going to he's got some disease and you are withholding that treatment for some reason, for your studies, that is not correct. So a placebo, but withholding treatment known to be effective is not. Okay. Using a placebo instead of the experimental drug is ethical, since the experimental drug is not known to be beneficial and could be actually be harmful. So you can use a placebo instead of the experimental drug. Like one group has got the experimental drug, the other group has got the placebo. You can use it, it's not ethical because we don't know whether the experimental drug will be good or not. We don't know whether it's got side effects. Then the problem here is ethics. Withholding known good treatment for disease is unethical. And exposing people to possible harm is also unethical. Okay. So many drugs are there which cause harm, which cause side effects. Like for example, streptomycin is still used in TB. During our time it was quite common. It can cause nerve deafness. Okay. So the types of RCT is what we will be doing mainly in your MD, evaluating therapeutic agents, interventions, mainly drugs. That's a clinical trial. Not always possible. Like for example, blinding in surgery, tonsillectomy. Then this is a RCT, pharmacokinetics in volunteers. When your volunteers, what do they get in their treatment? Does the drug, phase 2 is, does the drug prima facie have an effect? You are having first your trial on volunteers, healthy volunteers. They find that there is no particular effect. Then you come to the real people. Then you try to find out whether the drug has a real effect or not. Then comes the RCT. Okay. And then finally is the post-marketing survey for any new drug. Again, then you have what is called preventive trials, trials of vaccines and chemoprophylaxis. So RCT is one. The second one is preventive trials for vaccines and chemoprophylaxis. Then risk factor trials. The investigator intervenes to interrupt the usual sequence, like in the development of diseases. Here what is happening is, he's going for cardiac problem. So you make sure that his cholesterol is decreased, promotion of physical activity is there, physical exercise is there. That is the investigator intervening to interrupt the usual sequence in the development of disease. Then cessation experiment, like in a RCT group, one group stops smoking, the others continue to smoke. So that is again, this is a cessation experiment, but the other group is continue to smoke. So here again the question of ethics. Okay. Trial of etiological agents like retinopathy of prematurity, there is another one. Premature groups, babies weighing 1.5 grams, divided into experimental and control group. In the experimental group, all are given oxygen for 28 days, and control group received oxygen only in emergencies. So what happened was, retinopathy of prematurity developed only in the experimental group. That is, people who got 50% oxygen, they only developed retinopathy of prematurity. Also, this was another evaluation of health treatment. RCT also proved that domiciliary treatment for pulmonary TB was as good as hospital or sanatorium TB. Okay. Non-randomized trial is also there when disease frequency is low and natural history is low. For example, CA pancreas, small intestine, and viruses causing cancer. So you have uncontrolled trials, effect of pap smear and decrease in mortality from CA cervix. This is what I was just telling you. We have the pap smear, but now if we have the HPV vaccine, we can get the same thing, uncontrolled trials. Natural experiments, before and after comparison. Okay. So uncontrolled trials, there was no RCT, but today when we have, it proves that pap smear can reduce the mortality of the disease. And experimental studies, when the epidemiologist thinks for something which looks like mimics experiments, like in Athens in Greece, a study was conducted on the effect of stress on cardiovascular mortality, except deaths from cardiac causes, and external causes on the day after the earthquake. There was an excess of deaths from cardiac causes, but not from the external causes. So before and control, after comparison, with control, without control. Without control is, we had this one famous experiment of scurvy by giving fresh fruits. James Lind, who was a naval surgeon, he prevented them from getting scurvy. With control is before and after treatment, and it could be misleading. So here we look at in a study of preventive program to be applied to entire community. He would select another community as similar as possible to the frequency and the characteristic to be prevented. So here, to summarize, strict follow-up of the protocol, randomization, limiting the study to a limited person's number of factors, standardization, intensive training to observers. Like for example, this is something, use of hydroxychloroquine during corona. Protocol was selection of groups. Reference population was population of Chennai. Representative population of Coimbatore. And here the randomization, investigator has no control regarding who will be given the drug. This is a trial for, during corona we tried giving hydroxychloroquine, HCQ. Then study given, one group was given the medicines and the other group was given placebo, and final outcome assessed and recorded. Here the problem was what? Ethical issues present. You are denying treatment to a potentially fatal disease. You are giving a placebo to a person who got corona. Is it correct? Is it correct? You are giving placebo to somebody suffering from corona. Not correct. So that is why ethical issues present. That is, you are denying treatment to a potentially fatal disease. Then again, use of dexamethasone in corona. 2,100 patients received low dose dexamethasone for 10 days and 300 received standard dose. So dramatic effect found in those on ventilators, risk of dying reduced by 1/3. Okay. And risk reduced by 1/5 in patients receiving oxygen. So it was beneficial, the use of dexamethasone was beneficial. Preventive trial of corona, efficacy of vaccine during corona. After we were given corona vaccine, Covishield or whatever, there have hardly been cases of corona. We have not tested, of course. So, preventive trial for corona. Okay. Then risk factor trials, reduction of risk factors like comorbidities, travel, close contact, etc. And before and after for corona, number of cases increased after the flights opened and trains started running. Till then, number of cases less. But once the flights opened and trains started operating, the number of cases increased. So before and after studies. So that's all. Okay.